So once we enter the room, explained ourselves and what we're there for, we got our 2 patient identifiers to ensure we're in the right place at the right time with the right patient. Once that's done, I'm going to go ahead and set up my oxygen first. That way we can ensure that it's on and properly working before we get that tube out there. And then since our patient was on 30% oxygen on the vent, we're just gonna go ahead and go a little bit higher than that on the nasal cannula. So I'll start anywhere between 4 to 5 liters per minute. And we wanna make sure we see that bubbling. Place that right at the bedside so it's good to go when we need it. Now at that point, we would go ahead and check our cuff length. So you can do that 2 ways. You can either manually listen with your stethoscope, and that would just be around the neck. As you deflate the cuff, you should hear air movement. You can also do it by deflating the cuff and then checking the difference between your exhale tidal volume and your set tidal volume. And that should be greater than 20%. So in this case, our tidal volume is set at 600. So the greater that lower than 600 we are, the better. So let's say we get like 450, that's a good cuff length. That would indicate that we don't have a good risk for supra or subglottic edema, and that we won't have to worry about having a risk of re-intubation. Once that's done, we're going to inflate the cuff back up until we're ready to extubate. Make sure our suction equipment is good and functional. We're gonna go ahead, suction the mouth, and go in the actual tube with the inline suction and suction the tracheobronchial tree. We're gonna be in there for no more than 20 seconds. And if we do need to suction, we will hyperoxygenate the patient first. But in this case, we actually have clear breath sounds, so there's no indication for any need for secretion removal. Once that's done, we're going to go ahead and make sure that we have all of our vitals looked at. He is good on his sinus rhythm, he's good on his respirations, his saturations look good, his blood pressure is normal. Once that's done, we're going to get him ready for that tube. So, get our checks pad out and lay it right in here to catch all of that stuff once we do pull it out. We're gonna make sure we have our 10 ml syringe connected and ready. Okay. At that point, we would go ahead and put the vent on standby and disconnect the vent circuit right here. We would go ahead and loosen up the binds from his face while maintaining hold on the actual tube itself. And then we would go ahead, deflate the cuff all the way. And then I would go ahead and instruct him to take a big deep breath in, and right at an inspiration, I would pull it out. Once it's all out and onto the checks pad, I would instruct him to cough, and then we would go right back in with the suction. At that point, we would put his oxygen on. Around one ear, around the other, and then tightened up around his neck. And then since this is a nasal cannula, we would make sure the prongs are facing down when we put it in his nose, and that we have just tight enough to have like 2 fingers in there. Once we're done with that, we would go ahead, throw away all of our trash. We would reassess vital signs, make sure that nothing crazy happened while we were extubating him, and let him know that we would be back in 15 to 20 minutes just to make sure nothing is going on. There's no subglottic edema, no stridor, nothing like that that we would have to intervene for. Once that's done, we would go ahead, leave the vent at the bedside for 24 hours just in case, and then take all of our supplies, take all of our trash, wash our hands, and then go and chart.